We're going to move forward with the next talk. My friend and colleague from Oregon, who I really want to thank for joining us for this meeting, is going to give a talk on sort of trying to see, how which patients should get surgery, which patients should get transcatheter valve, and which patients should get nothing.
Thank you, Sushil. Well, that was a great talk about the past and the future and where we're going. So my job is to bring you guys back to the present and see how we now use this technology on a day-to-day basis. So hopefully I'll be able to just take a series of cases and then show you what the decision-making process is for some of these cases. They're all from my practice in the last few months. These are my disclosure slides. As you know that when this whole field evolved, the cardiac surgeons felt like they might not be part of the picture, whether this is in the realms of interventional cardiology. And I'll make the case also that Sushil alluded to it a little bit, that this is not an interventional procedure, this is not a surgical procedure, this is really a heart team procedure. The normal aortic valve, all of us know that this is a nice picture. When it opens, it's great, but stenosis, especially aortic stenosis, this slide has not changed much other than what Sushil mentioned as the demographics shifting to an older population. But when you are symptomatic from aortic stenosis, you have very limited survival, no question about that. We also know that as our populations age across the US as well as in India, I suppose, that more and more people have comorbidities that preclude them from being a good candidate for aortic valve procedures via the surgical approach. I won't spend a lot of time on the partners study design, just to tell you that there were two cohorts, cohort A and cohort B. Cohort B was the inoperable group, and these were really inoperable patients. Cohort A were high risk. The cohort B results were released a little bit earlier. And what they showed was a dramatic improvement in survival at 1 year, at 2 years in these patients. In high-risk groups, when patients were randomized to high-risk surgical AVR versus transcatheter valve therapies, they did about the same. So the risk assessment for aortic valve replacement is a continuum, as you can imagine. It goes all the way from the low-risk patients to the high-risk patients and beyond. And what we've done, as Sushil Center does and as a lot of other centers do, is this whole heart team approach on how we process these patients, how we have a shared decision-making. After the initial physician referral, a lot of these patients, as mentioned, have comorbidities, and a lot of their clinical and diagnostic imaging is gathered upstream. A lot of the imaging that doesn't exist we get before we actually ever see the patient, which includes coronary angiography, a CT of the chest, abdomen, and pelvis, which is absolutely critical to decision making, as I'll show you. And then they meet with the heart valve team, which is an interventional cardiologist and a cardiac surgeon. And then it really runs in a series of 3 or 4 different outcomes out of that meeting. Most of the time, we're able to decide right up front on what that decision might be. For example, the decision may be surgical aortic valve replacement versus a transcatheter aortic valve replacement versus some sort of temporizing measure or palliative measure like a balloon valvuloplasty. And then finally, real but diminishing number of patients where we say, boy, medical therapy, imperfect and unsatisfying as it is, might be the best approach. And even in the hospitals, we've restructured ourselves to be thinking more in each other's worlds rather than think in the interventional cardiologist world or think in the surgeon's world. We've got surgeons on one side who would do surgical AVRs. We have cardiologists on the other side with angiography, PCI, BAV. And then in the middle is heart valve service, which has its own outpatient clinic. We have bi-weekly clinic meetings. Obviously, the procedures themselves are done together. CMS, which is the funding agency in the US, has made sure that you can't bill for the procedure if you bill it as a single operator. It has to be billed as a double operator between a cardiac surgeon and an interventional cardiologist. And then the inpatient rounds are about, we just alternate, but they're really shared and joint rounds. So here's the patient. She's 77, has a history of COPD, peripheral vascular disease, a remote CVA with some left upper extremity weakness, but mostly recovered. She has the usual suspects for risk factors: diabetes, hyperlipidemia, hypertension, and then over the last several years has developed aortic stenosis such that she's now functional class 3 to 4. On an STS, which is the Society for Thoracic Surgeons risk assessment tool, her risk score is 6%. And just by show of hands, how many people will actually routinely use STS scores for deciding their patients? So not that many, but it's something that we now use routinely. There's a Euroscore and a log Euroscore, which is used more in Europe. And the STS calculator takes into account a number of risk factors which predict the outcomes after surgical AVR. It's, I think, a useful tool, not a perfect tool. For example, some of the factors that don't get into the STS database are factors that for any given patient may be prohibitive, such as porcelain aorta, hostile chest if they've had prior radiation and no surgeon would touch them, severe pulmonary hypertension or fibrosis. I think it's underrepresented, etc. So we take that into account, but don't necessarily use that as the sole criteria for clinical decision making. Getting back to this patient, we routinely do a frailty assessment. Now, frailty is a unique concept, and I guess we used to call it good judgment. And these are patients who you walk in and you say, I don't know what's wrong with you, but whatever we do would be to you rather than for you. And how do you substitute that in a numeric scale that substitutes for good decision making? Well, in the partner trial at least, some of the things that they used for are the 5-meter walk test, as in how far or how long does it take you to walk 5 meters? What is your albumin levels, which is a measure of your overall nutritional status? How independent are you with your activities of daily living? And how much of a grip strength you have as a surrogate for muscle mass? Our surgeons assessed her. In the US, it is required that 2 cardiac surgeons would assess these patients who are being considered for transcatheter valves, and the surgical risk was adjudicated as high based on all of her risk factors. Those are her PFTs down there. She had stenosis in the mid-RCA, and this was her echocardiography, severe aortic stenosis, but preserved LV systolic function, and then mean and peak gradients that would support that. So as a staged procedure, she underwent PCI to the right coronary artery with bare metal stents, and then about 6 weeks later came back to us for additional assessment. Now we take a very, very close look, as Sushil mentioned, at CT imaging. And some of the things we look on the CT scan would be, what is the size? Now, obviously, one of the problems is that you're trying to put in a round device into an annulus, a hole that is not round by definition. And then the second is, how big is the annulus? The initial partner trial, the initial clinical experience, all of these patients were done via 2D transthoracic echo. And as we all know, that is a very imperfect tool. The valve area here, you can't read this, but is in the 400 range, which allows us to figure out what would be the appropriate sized valve. We look at what the distances are of the right coronary artery and of the left coronary artery, simply because you don't want to jail those off. That would be catastrophic if it happens in left main and quite annoying in the right coronary artery. We look at their abdomen and pelvis, the vasculature, to see what sizes they are. In this particular patient, her vessels had a minimal luminal diameter of 5 millimeters. So the heart team adjudicated this patient as an appropriate candidate for transapical TAVR. And typically in our presentations, in our discussions, we would put out if there are any comorbidities and other things that we would like to be aware of during the procedure. She came to the procedure area and underwent a TAVR. This is a sheath that is inserted through the apex. And then the actual procedure, as Sushil pointed out, is pretty straightforward. She did great and was discharged day 4. Now here is another patient who's 87. Now he presents with COPD, CHF, and really class 4, almost in shock. He was supposed to see us, but then his wife got sick, and then several months later, he presented with a low blood pressure and class 4 heart failure, and EF that had diminished pretty rapidly from his baseline. Now, clearly, given his STS score of 18%, as well as that EF and his overall frailty, we didn't feel that he was a candidate for surgery. In fact, we didn't think that he was a candidate for TAVR also. These are the sort of patients who might or might not recover. And in this population, we start thinking about whether there's a role for balloon valvuloplasty. As you know, balloon valvuloplasty as a procedure had a lot of initial enthusiasm in the 80s, and then as realization dawned that almost all of these folks restenoze, it fell out of favor. But it has made a huge resurgence with the advent of these therapies. And the way I use it is, one, in somebody like him as a palliation device, perhaps as a bridge to recovery, and then you try and seize that window of opportunity between 4 and 6, 8 weeks before the valve has restenosed, but you've had the full benefit. So this gentleman actually had a nice recovery of his ejection fraction. It didn't go all the way to normal, but it went up to about 40%. And this is his initial BAV. So as Sushil pointed out, we rapid ventricular paced them. In this particular patient, we were concerned that the distance to the left main coronary artery was not sufficient. So we actually did an aortogram at the same time during the BAV. And those are just some 3D TEE images on the top right that show the balloon inflation. Almost always, this is a multimodality team and multimodality imaging assessment, fluoroscopy, and echocardiography. The rest of the process is fairly similar. He came back, the CT showed an appropriate size annulus, and he actually had appropriately sized pelvic vessels that would support the valve size that he needed. As I pointed out, we spent a lot of time because remember, these devices are bulky and you're only as strong as your weakest link, so all it needs is a little area of calcium, and you might not be able to advance your delivery sheath. That is an unsatisfying day to be sure. The procedure again is quite predictable now. The drama is no longer there. You cross retrograde, you put your sheath where it belongs, and then with rapid ventricular burst pacing, you deploy the valve, and it's fairly typical to get good results. Here's an aortogram right after the procedure, and this patient actually did great with a recovery of his ejection fraction to the normal range. Now, the spectrum of these patients is that just because they happen to land up in the complex valve clinic with an IC is not necessarily that TAVR is the best approach for them. Here, for example, is a 91-year-old retired physicist. He's very active in the community at the University in Oregon. He has a center that is funded by him for biomechanical engineering, and has a history of hypertension, and it's just been deteriorating over the last few months with angina. His STS score was not very high, but because of severe aortic calcification, low EF, we felt he was high risk. Here's his coronary angiography, and as you can see, he has severe multivessel coronary artery disease. The LAD is occluded. There is a disease in the distal circumflex. Hopefully the other side will play. That shows the LAD a little bit better. And I didn't feel that this was a good candidate for percutaneous revascularization. You know, the whole concept of revascularization pre-TAVR is a moving target. In the partner trial, it was required that all of these patients be as fully revascularized as needed. But our approach now is to look at them on what happens when you pace this ventricle, whether they're likely to survive a pacing run or not, and I based revascularization decisions based on that. He also had high-grade disease in the right coronary artery, with also collateralized the LAD. So we didn't feel that we would get a good result percutaneously here. High syntax score, the CTOs of the LADs and RCA might not be crossable. And he was adjudicated to surgical aortic valve replacement, where the procedural considerations were calcified aorta. He had some renal dysfunction, and risk for CVA, of course, is not unique just to transcatheter valves, but rather exists in this population, especially with surgical valves as well. And finally, the last spectrum, which kind of goes on the extreme risk. Here's a lady who I just saw last week, 82-year-old female, severe COPD, FEV1 of 0.7, a DLCO that is quite low, severe peripheral arterial disease and occluded right common iliac artery and left iliac artery of about 2.5 millimeters, carotid disease, functional class 4, diminished LV systolic function. And what she had was a lot of calcification. This is kind of, will go a little fast, but you can see that the mitral annulus is heavily calcified, and it calcifies all the way into the aorta and into the left main, such that we felt that even if we were technically able to do a procedure, it would lead to a rupture or a dissection. And this patient we adjudicated as best treated with medical therapy. Unfortunately, we didn't really think that we had great options for her. So the risk assessment model for aortic valve replacement in 2013, clearly the low and medium risk patients, surgical AVR, although as Sushil mentioned, in the intermediate risk group, trials are ongoing, and it remains to be decided what that optimal strategy might be. Certainly as the devices improve, as the paravalvular leak issue and the embolism issue, the stroke issue gets sorted out, those would become more and more attractive. In high risk, we have the ability to choose between SAVR or TAVR, and either one of these approaches may be okay, although we've gotten more sophisticated on what patients are now better served with surgical versus a transcatheter valve. In inoperable patients, if they're inoperable, clearly TAVR is the only therapy. And then beyond that, it's the extreme risk population where you would look at BAV or medical therapy alone. So you know, the whole continuum of this is seeing the surgeons as partner and really highlighting the role of the heart team that I think is key to this whole process. Thank you very much.